Assalamu alaikum. In this lecture, we will discuss the renal mechanism in the regulation of acid-base balance. What is the role of the kidney in maintaining the normal acid-base balance? The objective of this lecture is to discuss the role of the kidney and the way that is used to maintain a normal acid-base balance. Also, we will list the main type of the disturbance in the acid-base balance, and we will discuss the cause of each of them and how can we diagnose each of these abnormality, and how can we decide whether the acidosis or alkalosis is respiratory or metabolic in origin. The normal function of nearly all the processes in the body depends on maintenance of an appropriate acid-base balance. The value of the interstitial pH and the intercellular pH strongly depend on the arterial blood pH, which is usually between 7.35 to 7.45. When pH deviates outside this normal range, what happens? In this case, the pH-dependent enzyme and the membrane transport protein may not work properly. In addition, most of the metabolic pathway also can be negatively affected by this change in the pH. So, as a beginning to the subject, first we will define an acid as any substance that can give hydrogen ions. So we considered the hydrogen as the acidic compartment in this in the acid base compartment, while the base is any compound that accepts this hydrogen ion. As we know, the pH is equal to the negative log of hydrogen ion concentration. The diet usually is neutral pH and contain very little amount of acid. So the hydrogen in the circulation and the acidity come from where? Usually it comes from the cellular metabolism of the metabolite, the protein, the carbohydrate, and fat. When it is metabolized, it will produce acid, for example, sulfuric acid. So the acid must be either neutralized or excreted. Otherwise, if this acid remain in the circulation, it will change the pH from its normal range, which is 7.35 to 7.45, to an acidic pH. And in this case, most of the process will not work properly. And in case we have excess space in the food or whatever the cause, this will be excreted in the feces. So how can the body maintain the pH within its normal range? We have three main process or organ. First of all, we have the renal dealing with the excessive acid or the decrease in the acid. The first controlling mechanism is the kidney, and which is the subject of our lecture today. And we have the lung, we have the respiratory compensation, the CO2, the carbon dioxide. We consider it as an acid, and the lung can decrease the production or retain CO2 or increase the excretion of the CO2 according to the acid-base state of the body. And we will know what is meant by the respiratory compensation. And this type of compensation, the respiratory, is the first to response. We have the buffer system. We have many types of buffer system. The most important one is the bicarbonate carbonic acid. We have also the phosphate is a good buffering system. The proteins in the body also considered as a buffering system. We have this buffering system. We have intracellular buffer, including the phosphate and the protein buffer system, whether this protein is hemoglobin or amino acid buffer system, or we have the extracellular fluid, and the most important one is the carbonic acid bicarbonate buffering system. This equation is very important equation. We must put it in our mind. The CO2 plus the water will be converted to a carbonic acid that will be can be converted to hydrogen and bicarbonate. So this is considered as the basic compartment in this equation, and the CO2 is the acidic compartment. In case we have acidosis, the CO2 excretion, the equation will be shifted to this side, production of more CO2, and it can be excreted in the respiration to get rid of the excess hydrogen. And in case we have a decrease in the acid, we can retain the CO2, and in this case we can retain more bicarbonate. By this, it produce more bicarbonate by shifting the equation in this direction. So one of the buffering system is, or one of the system that maintain the pH within the normal range and maintain the acid-base balance is the kidney. We said we have the lung, the buffering system, and we have the kidney. The kidney have many way to maintain the acid-base balance. We have the sodium hydrogen exchanger. In this system, if we have excess hydrogen, it will be shifted toward maintaining, if we have excess hydrogen, excretion more hydrogen and retaining the sodium. The other mechanism is reclamation of bicarbonate, and we will know how to reclaim the bicarbonate. Production of ammonia and excretion of ammonium. So the difference between the ammonia and the ammonium is the etc. hydrogen in the ammonium. So by combining hydrogen with the ammonium and excrete ammonium, we will get rid of this hydrogen in case of acidosis. The other one is the other mechanism is excretion of hydrogen in the phosphoric acid. This is a buffer system that is used by the kidney. So the sodium hydrogen exchanger, in case we have excessive acid, excessive hydrogen, and the body want to get rid of it, normally it will be secreted in the lumen, in the tubular lumen, to be excreted within the renal, within the urine, and instead it will retain sodium to inside the cell. In case of alkalosis, it means that the hydrogen will be lower than the normal, and so this sodium hydrogen exchanger will be inhibited, and no hydrogen will be excreted instead of the sodium. While in acidosis, this sodium hydrogen exchanger will be enhanced so that more hydrogen will be secreted in the tubular fluid and excreted in the urine, and the body will get rid of the excess hydrogen and the pH will return to normal. This is the first mechanism by the kidney to maintain the acid-base balance. The second mechanism that is used by the kidney to maintain a normal acid-base balance is to reclamation of the filtered bicarbonate. Bicarbonate represents the basic compartment, and it is very important not to lose excess bicarbonate in the urine. So the part of the function of the kidney is to reclaim this bicarbonate. How can it reclaim it? We will see that we have already the bicarbonate is filtered by the glomerular filtrate and it is found in the lumen of the tubule, kidney tubule. So how can this return back to the circulation, this bicarbonate? It will combine with hydrogen in the lumen, in the tubular lumen, and it will form carbonic acid, H2CO3. Then this carbonic acid, by the enzyme carbonic anhydrase, will form CO2 and water. The CO2 will return back to inside the renal tubular cell, and again by the enzyme carbonic anhydrase, it will form the carbonic acid, which will break into bicarbonate and hydrogen. The bicarbonate is reabsorbed back to the plasma so that the bicarbonate will return to the body and the basic compartment will be preserved. I will repeat this. How one of the mechanisms of the kidney to maintain a normal acid-base balance is to reclaim or reabsorb the filtered bicarbonate, because it is very important to prevent the bicarbonate. It will balance the acidity that's formed in the body. So if we have excess loss of bicarbonate, what will happen? We will have acidosis. How does the kidney reabsorb or reclaim the bicarbonate? When the bicarbonate is formed or it is filtered by the glomerular filtrate and it is already in the renal tubular lumen, it will combine with hydrogen to form carbonic acid. Carbonic acid, by the effect of the enzyme carbonic anhydrase, will be changed to CO2 and water. CO2, because it is gas, it can diffuse into the renal tubular cell and it will combine with water. Again, by carbonic anhydrase, it will form carbonic acid. Carbonic acid will break to bicarbonate and hydrogen. So the bicarbonate is again, we reclaim it from the tubular lumen and from the filtrate into the inside the tubular cell. And in this case, it will then go back to the plasma and the bicarbonate is reclaimed or reabsorbed back to the circulation. The other mechanism that allow the kidney to compensate and participate in the acid-base balance control is that it can produce ammonium from the ammonia. The difference between the ammonium and the ammonia is that the ammonia is NH3 while the ammonium is NH4. It means that the ammonium contains extra hydrogen, one extra hydrogen. So the kidney can take the ammonia, extrude the ammonia from the glutamine and other amino acids, and then it will combine it with hydrogen in the glomerular filtrate in the tubular lumen, and it will form ammonium. It will form ammonium. Ammonium is insoluble and cannot pass back to the tubular cell, so it will be secreted in the urine. So it will take the extra hydrogen, the ammonia will take the extra hydrogen, and it will be excreted in the urine. The other mechanism done by the kidney is that the hydrogen phosphate found in the glomerular filtrate, filtered by the glomerulus, will bound to the hydrogen in the buffered hydrogen, also found in the glomerular filtrate. It will form H2PO4, which is the phosphoric acid, and it will be excreted in the urine. So, as a buffering system, the kidney can extract ammonia from glutamine and from other amino acids, and it will combine it with hydrogen to form the ammonium, and ammonium cannot return back to the tubular cell, and so it will be trapped and in the tubular urine and excreted in the urine. This is one way to get rid of the hydrogen in the and control the acid-base balance. And this one about 60% of the way to excrete hydrogen ion, And also the hydrogen phosphate combined with hydrogen. This is a buffer system. It will form the phosphoric acid and it will be excreted in the urine. These two buffer systems are very effective in getting the excess hydrogen from the body. In case we have acidosis, both of these will be enhanced to excrete more hydrogen, especially the ammonium system, buffer system. In case of acidosis, the phosphate excretion will increase, and this will provide an additional buffer for the hydrogen. It will react with the phosphate, the hydrogen phosphate, and form the phosphoric acid, and it will be excreted. This buffering system depends on the pH and on the amount of the phosphate that can be used, available in the glomerular filtrate, and it can be used as a buffering system. In case of acidosis, the phosphate excretion will increase, and this will lead to more formation of the phosphoric acid. So this is a good way to get rid of the excessive hydrogen. So in case when there is a deviation of the acid-base balance from its normal range, 7.35 to 7.45, then in this case, and the case of acidosis, when the pH decrease, then there will be excretion of more acid by the kidney, and the pH of the urine will be decrease because of excessive acid that is excreted in the urine. And in case of alkalosis, the acid excretion by all the four way we talk about in the previous minutes, the acid secretion will decrease and the pH of the urine will increase. Generally, the abnormality in the acid-base balance can be divided into four main categories. Either it is metabolic, acidosis or alkalosis, or it is respiratory alkalosis or acidosis. These are the main categories, but sometimes we will have mixed abnormality. For example, it could be combined metabolic and respiratory acidosis, or it may be metabolic acidosis and respiratory alkalosis, or it may be partial. So, but the main and the basic type are these four types: metabolic acidosis and alkalosis, and respiratory acidosis and alkalosis. In case of metabolic acidosis, it means that there is excessive loss of hydrogen, and there is excessive production of hydrogen in the body, or retention of hydrogen, or there is excessive loss of the bicarbonate. When we have a defect that is metabolic, then usually the compensation is respiratory by increasing the rate of CO2, either retention or excessive excretion to correct the acid-base balance. And if the defect was respiratory, whether acidosis or alkalosis, the compensation or the correction, by compensation we mean the attempt to correct or the correction mechanism, will be by the kidney. So if the defect mainly is in the lung, the compensation usually is by the kidney, and if the defect is in the kidney, metabolic acidosis or alkalosis, the usually correction or the compensation is respiratory. So the metabolic acidosis or alkalosis, it is related to defect in bicarbonate and other buffer system regulation, while the respiratory acidosis or alkalosis, it means abnormal removal or retention of the carbon dioxide, the CO2, from the body. So the abnormality in respiratory acidosis and alkalosis related to the CO2, and the abnormality in the metabolic disturbance is related to the abnormality in bicarbonate and other buffer system. So first, to know what is the defect, we must know the normal value of these important parameters. The pH normally is 7.35 to 7.45, while the PCO2 is 35 to 45 millimeter mercury. The bicarbonate level normally is 23 to 25 millimole per liter, and the chloride level is about 95 to 105 millimole per liter. According to these parameters, when we measure them, we can define whether the defect is the patient have acidosis or alkalosis, and if the defect was acidosis or alkalosis, the next step is to look to other parameters to see whether from this deviation of this normal parameter, we can know whether the defect is respiratory or it is metabolic defect. So, when we suspect that a patient have an abnormality, an acid-base abnormality, first of all, we will look to the pH. We look to the pH. If the pH is below the lower normal, below the 7.35, it is acidosis. If the pH is more than 7.45, the patient have alkalosis. The next question, we ask whether it is metabolic defect or respiratory defect. If the abnormality was basic and not mixed disorder, either we have respiratory acidosis or alkalosis or metabolic acidosis or alkalosis without mixed abnormality, generally speaking, the direction of change of the normal pH is the direction of the movement of the PCO2 and bicarbonate. In this condition, the disorder is metabolic. What do we mean by this? If the pH, for example, the pH is low and the bicarbonate is also low and the PCO2 is low, all are in the same direction or all decreased. In this case, we can say that the defect is metabolic. It is mainly metabolic, and because the pH decrease and bicarbonate decrease, which is the basic compartment, so it is a metabolic acidosis. While in case of metabolic alkalosis, we see that all the arrows are in the same direction. The pH increase, the bicarbonate also increase, and the compensation, we have the PCO2 increase. It means that the defect is metabolic, and because the pH increase, and then the defect is metabolic alkalosis. While in case of respiratory defect, we will see that the direction of change in the pH is opposite to the direction of change in the PCO2 and bicarbonate. In case of respiratory acidosis, the pH decrease. Why? Because the PCO2 is present in high concentration in the circulation, and the PCO2 is an acidic compartment. Any disease that will lead to retention of the PCO2 within the circulation, it will lead to acidosis. The pH will decrease, the PCO2 is retained, and it is the cause of the acidosis. And as a compensatory, the bicarbonate will increase. Why it increase? To correct, because it is basic, so its concentration will increase in the circulation as an attempt of the kidney to increase the basic compartment by retaining more of the filtered bicarbonate. In case of respiratory acidosis, what happened? The pH increase and the PCO2 decrease. The PCO2 is the acidic compartment that is regarding the respiratory. So the PCO2 decrease, any cause that will lead to hyperventilation and excretion of large or over hyperventilation, and there will be wash out of the CO2, and this will lead to decrease in the PCO2. And as a compensatory mechanism, the renal will try the kidney will try to decrease the bicarbonate by excreting more of the bicarbonate and decrease the reclamation of the bicarbonate from the glomerular filtrate in an attempt to compensate for this decrease in the PCO2 and trying to correct for the acid-base disturbance, and so on. So we will look for the pH. Usually, if all these are in the same direction, it is metabolic disorder. If the pH is decreased, then it is acidosis, and if the pH increase, it is alkalosis. And if the pH direction is opposite to the PCO2 and bicarbonate after compensation, it means that the defect is mainly respiratory. We take an arterial blood sample, we look for the pH. If the pH was less than 7.4, it is acidosis. And we look for so the pH is decreased, and because the PCO2 increase, it means that the direction is opposite. It means that why it is increased, because there is retention of the PCO2. Any cause that will lead to retention of CO2, this will lead to respiratory acidosis, and the bicarbonate will increase, and the renal compensation will be by increasing the bicarbonate reabsorption to compensate, because the bicarbonate is considered as the basic compartment. In case the pH is low, below the normal, and the bicarbonate is low also, then it means that there is decrease in the reclamation of bicarbonate. It is metabolic acidosis, or a decrease in the production of bicarbonate, or there is excessive loss of bicarbonate. In this case, the PCO2 will be low, and why it will be low? As a respiratory compensation. It will try to get rid of the acid by excessive breathing so that the PCO2 will decrease. And the same for the alkalosis, the pH, we look first for the pH. If the pH was high, it means we have alkalosis. We look at the bicarbonate and the PCO2. If the PCO2 was low, it means respiratory alkalosis, and any condition that will lead to hyperventilation lead to this condition. The renal will try to compensate by decreasing the bicarbonate reclamation, so that the correction in case of respiratory disorder will be metabolic or by the kidney, while in case of metabolic alkalosis, the bicarb pH will be high, the bicarbonate will be also high, and as a compensation, the PCO2 will increase as a respiratory compensation for this metabolic disorder. The first abnormality we will know about its cause is the anion metabolic acidosis. Before we will talk about the causes of metabolic acidosis, we will remember what we meant by the anion gap. It is the difference between the measured cation, the positive ions, which mainly are the sodium and potassium, and the anion, which are the chloride and bicarbonate in the serum. So the anion gap is the difference between the cation and the anion in the blood, and usually it is between 8 to 12 millimole or milliequivalent per liter. What is the significance of this equation? Why it is important? Because when we know that sometimes we have metabolic acidosis with normal anion gap, and sometimes we have metabolic acidosis with high anion gap, each one have a different cause. So it can help us in the diagnosis of the cause of the metabolic acidosis. Sometimes because the potassium concentration in the blood is low, it can be omitted. It doesn't affect the total or the final result. So the anion gap is equal to sodium minus chloride plus the bicarbonate. So the cation minus the anion. In case of metabolic acidosis, the bicarbonate will decrease. Where there will be no either any cause that will prevent the kidney from reclamation of the filtered bicarbonate, or sometimes the formation of the bicarbonate when it's decreased. So in this equation, the bicarbonate will decrease. In this equation, bicarbonate will decrease. What will happen if this will decrease? It will result that the anion gap will be high. Anion gap. So we have acidosis plus anion gap, a high anion gap. Why? Because the bicarbonate is lost. While sometimes the we have acidosis, and it is a metabolic cause, but the chloride increase, and this increase in the chloride will compensate for the decrease in the bicarbonate, and the overall anion gap will remain normal. So in case we have metabolic acidosis and the bicarbonate is low, this will result in an increase in the anion gap. We call it a high anion gap metabolic acidosis. Why? Because this bicarbonate decrease, so as a result the sodium minus chloride will be high. But if the bicarbonate decrease and the chloride increase at the same time, each will compensate for the defect of the other. The increase will dilute the effect of the decrease, and in this case the anion gap is still normal, so we call it normal anion gap metabolic acidosis, or we call it hyperchloremic metabolic acidosis, because the cause of this normal anion gap is the increase in the level of the chloride. How can this help us? By knowing the anion gap by a rapid calculation of the anion gap. So first we measure the pH, it was acidosis, then we will find that the bicarbonate decrease, and so it is metabolic. Then we look for the anion gap, and we found that the anion gap is normal. Then we will think that the cause in this condition, either there will be loss of bicarbonate from the GIT, or there will be excessive loss of bicarbonate from the kidney, as in case of renal tubular acidosis or renal failure. The kidney cannot reclaim or reabsorb bicarbonate, and in this condition we will have normal anion gap metabolic acidosis, and sometimes we have excessive loss of bicarbonate from the GIT in case the patient have a chronic diarrhea or fistula with excessive loss of the bicarbonate. While in case of metabolic acidosis, we check for the pH and it was low, and the bicarbonate was low, but when we measure the anion gap by the equation, this equation, we will find that it is normal because the chloride increase and the bicarbonate decrease, so overall the result will be normal. There is abbreviation for the causes to make the remembering easy. It is called multiplies M for methanol, while the U for the uremia, D for diabetic ketoacidosis, and the P for paraaldehyde excessive amount, and the I for isopropanol, L for lactate acidosis, and E for ethylene glycol, while S for the salsalate. And outside this abbreviation, we have certain drug overdose and alcohol abuse also will lead to increase in the anion gap metabolic acidosis. Usually the metabolic acidosis is compensated by respiratory part of this system. So when we have metabolic acidosis, we will have respiratory compensation. In case of metabolic acidosis, the opposite, the pH will be higher than normal, and the cause is excessive loss of acid, either also from the GIT in case of vomiting, because the stomach contains high concentration of the HCl, so when there is a vomiting there will be loss of acid, or in case of diarrhea also we will have increase in the acid loss, or there will be excessive loss of the acid from the kidney in case of, for example, mineralocorticoid, the aldosterone, or glucocorticoid, excessive amount or concentration, the glucocorticoid like the corticosteroid, or when excessive use of certain type of diuretic also will lead to metabolic alkalosis. And sometimes when we have excessive alkali, whether given orally or IV, also will lead to metabolic alkalosis. And because the defect is metabolic, so the compensation is what? The compensation will be respiratory composition, and the body try to get rid of more, and by hyperventilation it will wash out more and more CO2, so to get rid of the to correct this metabolic abnormality. This in case of acidosis. While in case of alkalosis, the opposite will occur. The respiratory system try to retain CO2, and so that the acidic compartment that results from the CO2 will compensate for the metabolic alkalosis. So in case of metabolic acidosis, there will be hyperventilation to eliminate the excessive CO2, while in case of metabolic alkalosis, there will be retention of CO2 to correct for this abnormality. The respiratory acidosis occurs when the pH is low, and we will see that the CO2 is high because of retention. Any cause of CO2 retention will lead to respiratory acidosis. It could be local cause due to the chest wall abnormality or airway obstruction, or it may be due to a CNS disorder that inhibit the respiratory center, so that the CO2 will be retained in the body and cannot be excreted, result in acidosis, because the PCO2 represent the acidic is an acidic compartment, and in case when there is any defect that affect the respiratory muscle, maybe due to myopathy or neuropathy as in Guillain-Barré syndrome, and myopathy in case of myasthenia gravis, all these will lead to paralysis or weakness of the respiratory muscle, so that the body cannot get rid of the PCO2. It will remain inside the body and cause acidosis, and the correction or the compensation in this condition will be metabolic. In case of respiratory alkalosis, the pH is increased and the PCO2 and bicarbonate will decrease, and in this condition, when there is hyperventilation and there will be excessive loss of PCO2 in the respiratory system, for example, in case of hysteria, it will lead to respiratory alkalosis. In case of CNA stimulation by certain medication, that will stimulate the respiratory center, and there will be wash out of more of the CO2. This will result in decrease in the amount that is found in the below the normal range, and the pH in this condition will increase. And in this condition, the compensation will be metabolic. Thank you, and ready for any question.